little earlier, but still stayed back for this wonderful session. So I'm JP. I'm one of the cardiothoracic radiologists from Wake Forest, and I'll be moderating this session. Very brief introduction about AREP, which is Academic Radiology Education Program. This is a nonprofit initiative aimed at providing high-quality radiology education to colleagues worldwide. This was established in October 2021, and it's based at the Department of Radiology at Wake Forest University School of Medicine. So we offer free online education resources and live webinars featuring academic radiologists from leading U.S. institutions. This program is designed to bridge education gaps, particularly for radiologists in resource-limited settings, by sharing expertise and fostering global collaboration. We host bi-monthly webinars from January to October, covering various radiology subspecialties. These sessions are well attended with up to 700 participants per live event and include contributions from esteemed institutions. AREP's reach extends to radiologists in different countries in Asia, Africa, and Middle East. The program's success is driven by the dedicated of its committees, moderators, speakers, and who works tirelessly without external funding. So today I'd like to welcome Dr. Paul Bunch, and he's our speaker today. He's a professor at the Department of Radiology and Department of ENT at Wake Forest University School of Medicine in Winston-Salem in North Carolina. He's my colleague and a great friend of mine. He's a rock star in neuroradiology, most of you know by now. He's earned his medical degree from University of Virginia in School of Medicine in Charlottesville, and is currently pursuing he's already done the Masters of Science in Translation and Health Sciences from Wake Forest University. He completed his radiology residency at Brigham and Women's Hospital at the Neuroradiology Fellowship at Massachusetts General Hospital, both in Boston. His primary clinical and research interests relate to head and neck imaging, including primary hyperparathyroidism, head and neck cancer, and head and neck anatomy. It's not wrong if I say he's an authority in hyperparathyroidism and 4D CT. He also serves as the editorial board for radiographics and on the head and neck subcommittee of the RSNA annual meeting program planning committee. He's also serving as the neuroradiology division chief at Wake Forest, and also he's the vice chair of faculty development. So welcome, Dr. Paul Bunch, and the stage is yours. Thank you, sir.
Awesome. Thank you so much. Are y'all able to hear me okay?
Yes.
Cool. Awesome. And see slides now? Excellent. All right. Well, thank you so much for being here, whatever time of day it is, wherever you are in the world. It's really a privilege to have the opportunity to speak with you for a little while. And we're going to talk about primary hyperparathyroidism and parathyroid CT. I do have a couple of financial relationships in addition to my employment at Wake Forest. So with our time together, what I hope to do is to give you a little bit of a sense of the role and rationale of imaging in this particular disease. And we can't do a head and neck talk without talking about some anatomy, a little bit of embryology, and then I'll go pretty heavy on the operative considerations so that hopefully by the end of this time, you have a clear sense of what the surgeon wants to know from us and hopefully why, so that you can then apply what I hope you'll find to be a practical approach to parathyroid imaging, particularly parathyroid CT, which is what one of the focuses of my clinical areas is. I won't read this to you, but for those of you who like to have a sense of where we're going over the time, this is kind of how we'll get there. All right, so when I talk big picture, if I'm looking at a CT and I'm asking myself, could this be a parathyroid adenoma? That patient is going to fall into one of two buckets. One of those buckets is that they have known primary hyperparathyroidism, in which case kind of we're in a set of circumstances, and we'll expand upon that quite a bit with this talk. The other possibility is that they don't have diagnosed primary hyperparathyroidism. And so I just want to introduce you to this idea if you're not familiar with it, though we won't spend a lot of time on it. It's really a separate talk in itself. A lot of people, when they talk about primary hyperparathyroidism, they'll say, this is really diagnosed with blood tests. It's a little more complicated than just the serum calcium and the serum parathyroid hormone. But if you have those two pieces of information, you've got a pretty good sense of whether they do or don't have this disease. And there's no argument for me on this statement. They'll also say that we perform imaging for localization to tell the surgeons where these abnormal glands are so that they can hopefully plan the right surgery for their patient. And again, I'm totally on board with that. Kind of, if we accept these two things as true, some people will then go on to say, and I myself have said at different stages of my career, and maybe even written this down, that imaging really has no role in diagnosis. And this is where I think we should be a little bit more thoughtful and maybe question a little bit, kind of depending on which of those two buckets the patient is in, right? So if they have known primary hyperparathyroidism, I totally agree with this idea that we're really not imaging to diagnose them. They already have that diagnosis. We are imaging to localize. But if it's a patient that doesn't have a diagnosis and we see something that looks like a parathyroid adenoma, I would assert we might have a role to play in that diagnosis. And that's an area of active research that I think our field could benefit from understanding further. So this is an example of a 50-year-old female presented with submandibular pain. They got an neck CT to evaluate that. And I'm going to show you a lot of parathyroid adenomas over the course of this hour. And hopefully at the end of it, you'll say, yeah, that's what that looks like that could be. And so in our practice at Wake Forest, when we see something like this in a patient without known primary hyperparathyroidism, this is often how we'll report it. That biochemical testing is really calcium and parathyroid hormone level. And I think a fair question is, what does that cost? And at least in the United States, that costs about $100. So that's a lot of money for a lot of people in the US and in the world, but at least in the context of healthcare in the United States, $100, if it diagnoses something that has its own problems that we'll talk more about, can lead to treatment, I think could be money well spent in some circumstances. So I'm going to kind of leave this topic here. We're not going to talk much more about this sort of incidental or opportunistic assessment. We're just going to focus now on known primary hyperparathyroidism. This is as simple as I can possibly make the endocrinology. Parathyroid hormone acts on various organs in various different ways to increase serum calcium. When you have a problem of the parathyroid glands themselves resulting in elevated parathyroid hormone, we call that primary hyperparathyroidism. And that's really the flavor or the type of parathyroid disease that we're going to be focused on with this talk. This represents the most common cause of hypercalcemia. It tends to be a disease of middle age to older women. This is Sophie, Barbara, and I'm blanking on the third person's name, but they run a patient experience blog about kind of having lived with this disease, being diagnosed with it, having the surgery for it for anybody that's interested. No one really agrees entirely on how common this disease is. You'll see prevalence estimates all over the place. Everyone agrees the prevalence is increasing, and the upper limit estimates are about 1%. When I was in medical school, I learned a lot about the kidney stones, the skeletal disease, maybe some of the mental effects. But it's associated with a lot more than just that. People continue to study this, more and more information comes out, but it's been linked to pretty big problem, high morbidity diseases like heart attack, stroke, or even death. And so if you kind of bundle all of these associated things together, it's arising in patients with this disease, it is a pretty big contributor to healthcare costs. And an important fact is that how long you're living with this disease untreated is the primary determinant of what end organ effects and how severe you will develop. It is diagnosed with laboratory testing, as we've already said. Most commonly, or the most appropriately, starting point, calcium and parathyroid hormone. Usually it is a one gland problem, meaning that there is a single hyperfunctioning parathyroid adenoma, a benign neoplasm, resulting in this. In a minority of patients, they have multi-gland disease or multiple adenomas, as we've come to learn, and I'll say a little bit more about that in a second. And then very rarely, it can be the result of a cancer, a parathyroid carcinoma. So back in 2021, the WHO updated their CNS brain tumor classification, and that got a lot of attention and a lot of papers were written about it. Less attention paid in 2022 when they did the same with their parathyroid tumors. But on that previous slide, you'll notice that I had multiple adenomas, and some of you may have learned about, well, what about like parathyroid hyperplasia as a cause of primary hyperparathyroidism? And with genetic studies, and as we've learned more and more about this disease, it's become apparent, at least according to the WHO, that multi-gland disease is actually multiple clonal proliferations, multiple neoplasms, and they say it's best referred to as multiple adenomas, and that this idea of hyperplasia is best reserved for secondary hyperparathyroidism, most often due to renal disease, but can be due to vitamin D deficiency and other things. And so that's the reason for that terminology change that I think not everybody yet has familiarized themselves with. Let's talk a little bit about treatment. So surgical treatment, here on the slide, I've got only cure. Maybe it's fair to say is the preferred cure. There are places that will try to ablate these with an interventional radiology procedure, but by far and away, surgical removal of the hyperfunctioning parathyroid tissue is the most widely accepted cure. And there are two operative strategies for that you see listed here on the slide. The bilateral neck exploration is the original surgery, and it involves a relatively large, not huge, but big enough that the surgeon can access both sides of the neck to examine all of the parathyroid glands. And so that surgeon, he or she, will both visually, tactilely look at the parathyroid glands and remove the ones that appear to be most abnormal. Because it's a bilateral surgery, both of the recurrent laryngeal nerves are going to be at risk. The good news is that there are excellent long-term cure rates with low morbidity in experienced hands. As in many other areas of medicine, there has been a trend toward minimally invasive approaches, and parathyroid surgery is no exception to that. And in most centers, not all, but in most, this has become the preferred operation when appropriate. And what this allows the surgeon to do is to potentially make a very small incision at the site of what's presumed to be a single adenoma, and just remove that one gland and be done with it. In order to do this, the surgeon needs to have a great idea, very clear localization of where that single adenoma is. And that's really where we come in. Because nothing is certain in taking out one gland, you don't necessarily know it's going to be a single adenoma. They often couple this minimally invasive approach with something called intraoperative parathyroid hormone testing. And so a fact about parathyroid hormone is that the half-life is so short that if you take a measurement before the surgery, take a measurement several minutes after you remove what you hope to be a single adenoma, you can expect to see a substantial drop in that blood parathyroid hormone level that tells you, yes, you likely cured that patient. And if you don't see that drop, the surgeons will typically convert to the bilateral neck exploration. The surgeons have studied these two operations, compared them to one another, and shown numerous benefits with the minimally invasive approach in well-selected patients. And I've listed some of those here on this slide. And so this really brings us right to our widely accepted role and reason for imaging patients with proven primary hyperparathyroidism. It is to find the hyperfunctioning parathyroid tissue that the biochemical tests tell us must be present. And if we can localize a single adenoma, then we facilitate that minimally invasive surgery and all the associated benefits. Not everybody's going to be a candidate for that, right? A minority will have those multiple adenomas or that multi-gland disease, but localizing those also helps our surgeons because they know exactly where to go. If imaging does not find an adenoma, it doesn't mean the patient doesn't have the disease, right? We know they do from the biochemical testing. And so there's still a surgical candidate. It's just that the surgeon is kind of flying blind, or at least without the benefit of imaging localization. We're going to talk just a little bit about anatomy and embryology. There's really no way around it in a head and neck talk. So most people have 4 parathyroid glands, a superior and an inferior on each side. The superior glands derive from the 4th pharyngeal pouch, whereas the inferior derive from the 3rd pharyngeal pouch. And there's some more words here that I'll let you read. But what I want you to notice in this diagram is that when we view this layout or distribution of parathyroid glands from the front, it looks like there's a lot of overlap in where the superior glands are located in red compared to the inferior glands in blue. But when we turn and look from a different perspective from the side, something interesting happens. these superior glands cluster posteriorly within the neck, and the inferior glands cluster anteriorly within the neck. And the plane of demarcation, or the line of demarcation, is that of the recurrent laryngeal nerve. I'm trying to get my arrow over here. I can't seem to see it, but hopefully you can see the recurrent laryngeal nerve within the tracheoesophageal groove on the diagram. And of course, I can't see that recurrent laryngeal nerve, at least on the imaging I have available to me. And so I use the tracheoesophageal groove as the correlate for where that should be running to help inform, is this a superior gland or is this an inferior gland? The kind of a inconvenient truth, but nevertheless important fact, is that these big superior glands can actually descend in the neck. So just because it's low in the neck doesn't mean it is an inferior gland. And the surgeons refer to this phenomenon as acquired ectopia. And then the diagram is showing you kind of a normal size superior gland and then a larger gland kind of becoming low in the neck. And so I want you to see on the sagittal CT image how far posterior that adenoma is. I'm not a big mnemonic person, but if you are, if these help you, the best that I can come up with to help remember this is that the P's in superior and posterior stick together, and the N's in inferior and anterior stick together. And so that may seem like kind of just an academic point or trivia in some way, but I think it's not always the case. And I'll show you this illustrative case in a minute. Most often, that distinction helps the surgeon by telling them how deep they're likely to need to go in the neck. Again, the inferior glands are more anteriorly positioned. And it also informs the risk to the recurrent laryngeal nerve. If it is an inferior gland, it should be by definition anterior to the plane of the recurrent laryngeal nerve. So they should get to that adenoma before they get to the nerve. Whereas if it's a superior gland, it is by definition posterior to that plane. And so they're going to have to navigate crossing the nerve, hopefully without injuring it, to get to that adenoma. Let's look at our illustrative case. So here I've got planar Sestamibi images showing some focal, this is a delayed image, I believe, focal uptake in the left low neck. And I want you to appreciate how far posterior that is on the lateral projection. Here's the fused SPECT CT showing what looks like an adenoma kind of along the left posterolateral aspect of that patulous esophagus. I don't have the report from this study performed at an outside facility, but I do have the operative note. And in it, they said that they did a left inferior parathyroidectomy because a left inferior parathyroid adenoma was identified on Sestamibi scan. And so I think it's good to, always question the information you're receiving, and this would be no exception. And so does it make sense for where we see that to be in the neck, how far posterior that is, that it would be an inferior adenoma? This surgeon at this facility did not use that intraoperative parathyroid hormone testing to make sure that there was an expected drop after removal of whatever they took out. And at this patient's 6-week follow-up clinic visit, her calcium was still quite elevated. It was like 11 point something. And so she was referred to our facility. We did a parathyroid CT, and I had to kind of tell the surgeon, like, I don't know what they took out in the left anterior neck. But this thing right here on the image is the same thing we saw on that SPECT CT. And so, if it's hard to keep track of this anterior posterior thing, I think you don't have to necessarily say, I think this is a superior adenoma, or I think this is an inferior adenoma. If you're just descriptive and say this is, posterior to the esophagus, any surgeon that ought to be doing this surgery will know, okay, what that means is I'm going to have to get past the recurrent laryngeal nerve. I'm dealing with one of these inferiorly descended superior adenomas. Few words on ectopic glands. If you read the literature, they'll say up to 1 out of 6 parathyroid adenomas or parathyroid glands, even is in an ectopic location. I'm showing you examples in retropharyngeal, intrathyroidal, mediastinal, and carotid sheath locations. And this is almost certainly going to alter the operative approach, right? Because they'll have to figure out a ways to get there. The belief, at least, is that the inferior glands are more commonly ectopic because of their longer embryonal migration arising from that third pharyngeal pouch. No one knows that for certain, of course, but that's at least how we explain it through theory. The last anatomic and embryologic point before moving on to something else relates to the recurrent laryngeal nerve and its relationship to the right subclavian artery. So in the normal situation, the right vagus nerve will course along the carotid, pass anterior to the right subclavian artery, and then give off the recurrent laryngeal nerve, which will loop underneath, and then ascend in the right tracheoesophageal groove. And that's because of this embryologic link between the right vagus nerve and the right subclavian artery. In the setting of an aberrant right subclavian artery, that embryologic link is disrupted. And now the course of the right recurrent laryngeal nerve to the larynx is variable and it's unpredictable. And as a result, there's a much higher risk of operative injury to this structure, especially if the surgeons don't know about it. So when I see this finding of an aberrant right subclavian artery on preoperative imaging for somebody that's going to go for parathyroid surgery or for thyroid surgery, I'm going to put that finding in the impression. Now, for completion's sake, the same thing is true of the left recurrent laryngeal nerve. If you have a right aortic arch with aberrant left subclavian artery, that's obviously a much less common variant. And so most of the time we're looking at an aberrant right subclavian artery, but I just want to highlight that for sake of completeness. All right, let's talk a little bit about localization techniques. I've grouped these into what I would say are widely used and then some that are, I would call emerging. And really the big three, I think, are ultrasound, sestamibi, and then parathyroid CT. In Europe, some of you may be practicing in Europe where PET has really taken off, and I think there's some really amazing data on its effectiveness and utility. But at least in the US, for the time being, that's really reserved to a small number of centers. And the commonality of all of these is these are ordered after definitive diagnosis through that biochemical testing. I'm going to share just a few personal opinions before we move into each of these modalities. I think all of these imaging modalities have value. I don't think there's any single one that is going to be best for all situations. And so I'm thankful for the fact that we do have multiple tools available to us, and things like institutional expertise, institutional preference, surgeon preference are going to play a role here. And I think it's often the case that combining these to try to increase your confidence and the surgeon's confidence in an accurate localization is appropriate. And so that's something I commonly see done, and I think is not particularly redundant. A few words on ultrasound. This is pretty much everywhere. It seems like it's in our surgeon's office. Often the surgeons have done an ultrasound before they refer the patient to us for any additional imaging. And one of the nice things about ultrasound is it is the optimal modality for assessing for concurrent thyroid pathology, right? So no surgeon is going to want to do the perfect parathyroid surgery and leave a thyroid cancer in the neck. So if we see something on ultrasound that warrants further evaluation, maybe with FNA, then they might be able to do two appropriate surgeries at the same time in that subset of people that have thyroid problems and parathyroid problems as well. And if we see something on CT or MR in the thyroid in a patient getting worked up for parathyroid surgery, I think it's worth getting an ultrasound to further assess that. I'm showing you some sensitivity and positive predictive value metrics taken from the literature, and I'm highlighting that the ultrasound is less ideal for things that are hard to see with ultrasound, right? So if you have a poor acoustic window, either to the mediastinum, to the retropharyngeal region, behind the clavicle, it's going to be hard to see that with ultrasound. And the smaller the gland is, the harder it is. And all modalities do less well with multi-gland disease, but ultrasound and also sestamibi are kind of particularly challenged in that situation. The other thing I'll say about ultrasound is parathyroid adenomas almost always will be homogeneously hypoechoic relative to the thyroid gland. And then you will often see what's referred to as a polar vessel because these glands have a polar blood supply rather than the hilar vessel coming into a lymph node. Parathyroid CT, most commonly this is done as a 3-phase study. Some places, originally it was described as 4 phases. I think that's probably excessive. Some places do 2, just the non-contrast on the arterial, or perhaps even just the arterial phase. With Wake Forest, we're using 3 phases. I will say that the non-contrast on the arterial, I find the most useful. So if I had to dial it back or I wanted to dial it back, I probably would feel comfortable using those 2. Dr. Wong and colleagues did an international survey about a decade ago now, and at that time, at least, this 3-phase protocol was the most commonly used worldwide. I think there are a lot of advantages to parathyroid CT, and one of those is when you're talking to your surgeons, they're very comfortable looking at CT already. They're using CT for all the other stuff they do, and it shows them the relationship to the trachea and the carotid and all the other stuff that they care about. Whereas sometimes the sestamibi and other nuclear medicine studies may not give it to them as well. The acquisition times are quick. Sensitivity, positive predictive values from the literature I'm showing you, and compared to ultrasound and also compared to sestamibi, which I'm realizing I don't think I have a slide on here, this is more sensitive for multi-gland disease. And then in patients with negative ultrasound and negative sestamibi or prior surgery with recurrence or persistent disease, the literature has shown parathyroid CT to be particularly effective in these challenging scenarios. It's not without disadvantages, right? These take quite a while to interpret, at least in my experience, and there's a learning curve to it. And so if you are not currently doing this in your practice, but you're interested in starting, I would say that's awesome. You should definitely go for it. But don't expect necessarily to see results like those in the literature right away. You'll get there, but it will take some time and it will take some talking with your surgeons and some feedback. There's no avoiding the iodinated contrast media. So patients with anaphylactic allergy, for example, this is just not an option. And there's also no avoiding the associated ionizing radiation. I'm going to switch now and talk just about kind of a broader approach. And so this is sort of like a mentality or a mindset. Regardless of the modality I'm using to image a patient with primary hyperparathyroidism, my goal is to give the surgeon a detailed and accurate roadmap of the neck, telling them exactly where the abnormal parathyroid tissue is located. I'm going to try to use surgical landmarks that are relevant to them, and we'll talk about what some of those are in a little bit. I think the nice thing about parathyroid imaging and really head and neck imaging as a field is the differential diagnoses are usually pretty short. They're informed by the location largely. And so if you know that, then you kind of know your differential. The challenge here is that we're looking for very small things quite often that are variable in where they are located. And I said most people have 4 of these. Some people have fewer. I've seen in the literature up to 13 parathyroid glands, I think reported in a cadaver study, and I hope never to have to read that parathyroid CT. So I'm a stickler for getting as high quality images as we can. This is our dual energy CT acquisition, and I'm happy to share this with anybody. I want to highlight, we scan from the maxilla down through the carina, and we do that across all 3 phases. Some people will limit the non-contrast phase just to the thyroid region, but for several reasons that I won't go into in our limited time, I think it's easiest to just do it the same for all 3. And I'll talk about why I like dual energy in a minute. We recently got a photon counting CT, and so we may switch to that. But I've just been so happy with this dual energy protocol that it's almost like if it's not broke, why try to fix it? Other tips for scanning these patients, if we can do it, we will try to inject the right arm, get the shoulders as low as possible, and coach them not to move or swallow. Injecting the right arm avoids the really dense contrast crossing the midline from the left, like I'm showing you in this example, potentially obscuring a lesion from that beam hardening artifact. And the reason we want to get the clavicles low is to avoid artifacts like this that could similarly obscure lesions. I want to say just a few words about radiation considerations. So ultrasound and MR as well are associated with no ionizing radiation. So that's a great thing. And it is a fact that parathyroid CT is associated with more radiation to the patient than sestamibi SPECT or SPECT CT. Dr. Wong's group, using BEER7 model assumptions, calculated the attributable increased cancer risk from one parathyroid CT over the lifetime to be about 0.5% compared to about 0.2% for sestamibi. And there I want to highlight, this is compared to a lifetime baseline risk of nearly 50%. And unlike pulmonary embolism CT that patients may get 10, 20, 30 times in their lifetime, depending on their respiratory status when the provider happens to encounter them, these parathyroid studies are performed for the vast majority of people exactly once. And so my belief is that if we are being skimpy with the radiation for a patient who is known to have a disease that is going to have surgery, and they fail to get cured from their surgery because we missed something that we could have seen if we had better quality images, to me, that I think that radiation spend is worth it for these patients. but reasonable people can disagree on that question. All right, let's switch to image interpretation. There aren't a lot of always in radiology or life in general, and even this one comes with an asterisk, but parathyroid adenomas should be hypodense or hypoattenuating relative to the normal thyroid gland on non-contrast CT. And that's because the normal thyroid has iodine and parathyroid glands do not. That asterisk comes into play because not infrequently you'll have patients that have a thyroid gland that looks like this. It's low in iodine. And these are more challenging to interpret, and we'll talk about some strategies to help with that in a bit. A lot has been written about enhancement patterns with this so-called classic enhancement pattern where the adenoma is hyperattenuating on the arterial phase and then washes out or is hypoattenuating relative to the thyroid on the venous phase. The thing I want to really emphasize is that that pattern is observed in the minority of cases, about 1 in 5. A polar vessel, just like on ultrasound, can be seen on CT. So if our classic enhancement is only 20% of the time, that means more often we're going to have some version of non-classic or variant enhancement. And I'm not going to say a whole lot about this other than to just expose you to that idea and then come to a pitfall that I see when I'm reading with our residents and fellows. And that is that they'll sometimes rely too much on the enhancement pattern to decide whether they think something on CT is likely to be a parathyroid adenoma. And so the question I put to them, or I put to myself, is this clearly thyroid tissue or thyroid nodule? Is this clearly a lymph node? Is this clearly a blood vessel? And if it's not, I'm typically going to err on the side of describing that, whatever it looks like, if it's in the right anatomic location, as a potential parathyroid adenoma, again, because these people are coming to us with a proven diagnosis. And so some years at RSNA, they have these horse or zebra sessions, and I've been asked to talk on this related to parathyroid disease. And I've said, if you're in the bucket of known primary hyperparathyroidism, resist the temptation to think about zebras. It's either going to be a horse or it's going to be a horse disguised as a zebra. These parathyroid adenomas can really look like whatever they want to. They can have cystic foci. They can have fatty metaplasia. They can calcify. And so again, it comes back to if I'm not confident it's thyroid gland, lymph node, or blood vessel in a patient with known disease, I'm going to think, this could be a parathyroid adenoma. Here's an illustrative case of a 62-year-old female with primary hyperparathyroidism. We see this really like hypoattenuating structure in the left low neck. Certainly not the classic enhancement pattern, but again, we said we're not going to rely on that too much. I don't think it's thyroid. I don't think it's a normal lymph node. So I'm going to describe this potentially as a left inferior parathyroid adenoma. This patient had a failed previous surgery, and so they did another test, which involved selective venous sampling and catheter arteriography. Interestingly, this lesion was hypervascular on arteriography, and it was proven to be an atypical appearance of a parathyroid adenoma. Here are examples from 2 different patients given to me by one of my mentors, Dr. Hillary Kelly. The patient on the left of the screen has these 2 large cystic appearing central compartment lesions. They had known primary hyperparathyroidism. These were proven to be bilateral superior parathyroid adenomas that had a cystic appearance. This next patient was thought to have a thymic cyst, but they also had primary hyperparathyroidism. And imaging did not show any other lesions in the neck or mediastinum. And so what they did here is they did something called PTH washout. They placed a small needle, injected some saline, aspirated that, and then sent that for parathyroid hormone level, which was markedly elevated. And so this was resected, and this was proven to be a large cystic mediastinal parathyroid adenoma. Multiglandular disease or multiple adenomas, it's hopefully intuitive that if you've got multiple candidate lesions, then multigland disease is more likely. What may be less intuitive is that the literature tells us if we do not find any candidate parathyroid lesions, those patients are more likely to have multigland disease. And if our largest lesion is on the smaller side, like less than 7 millimeters, that's another feature that suggests the presence of multigland disease. And this is good to find, right? This allows them to plan the bilateral neck exploration to remove the abnormal glands. Parathyroid carcinoma is quite rare, and usually it's a surprise on histology. It's not something that very often we're suggesting prospectively. Potential clues are you have a young patient or you have markedly elevated parathyroid hormone, like in the thousands. Calcifications, we can see those with adenomas. This one happened to be a carcinoma with calcifications, so I don't think that that in and of itself necessarily helps you. But if you're seeing calcifications in the presence of some of this other stuff, it might. What about some mimics? So exophytic thyroid tissue, if you're only looking at the arterial phase, it might be tempting to say, you know what, this could be a right superior parathyroid adenoma. And so that's why I think it's really important to have that non-contrast phase and to look at it carefully. And so here is the corresponding non-contrast phase in this patient. And along the periphery, especially posteriorly, we see this rim of hyperattenuation. Why is that there? It's because that's iodine. So this is an exophytic thyroid nodule. Like we said earlier, we don't want our surgeons to do the perfect parathyroid surgery and leave a thyroid cancer in the neck. So if we see a suspicious nodule or a nodule of a certain size, it's probably worth getting an ultrasound before they go to surgery. Another pearl that I'll share is to use all the information you have available to you. And I said earlier that on ultrasound, parathyroid adenomas tend to be homogeneously hypoechoic relative to the thyroid gland, and you may see a little bit of an echogenic capsule. And so this is a case of an 82-year-old male with primary hyperparathyroidism who came to us for parathyroid CT. The surgeon had done an ultrasound in her office and had identified this as a potential candidate lesion. Now look at the non-contrast. It does look hypoattenuating largely to the thyroid gland. It's avidly enhancing on the arterial phase. It doesn't wash out in the venous phase, but we've already said we're not going to put too much stock in the enhancement pattern. We're going to broaden our horizons of what we'll accept as potentially a parathyroid adenoma. So here I was kind of on the fence. I'm not sure, and that's okay. But what I did was I looked at her ultrasound. And I said, you know, this thing that we're looking at here is homogeneously hyperechoic to the thyroid gland. Never say never, but this would be very unusual for a parathyroid adenoma, such that it made me think this is probably just a thyroid nodule, maybe a little exophytic. Let's keep looking. And back behind the esophagus, we see a nice candidate with a polar vessel. And not surprising, she was not able to see this on ultrasound because the acoustic window back there is pretty difficult. So she did a minimally invasive surgery, started with this candidate, did intraoperative PTH, and that PTH dropped as she would have hoped after removing this one lesion. And so that thyroid nodule got to stay in the neck, and this patient was cured of his disease. Quick word on lymph nodes, right? We have lots of central compartment lymph nodes. Sometimes it's hard to decide, is this just a lymph node? Is this potentially a parathyroid adenoma? And again, if I'm not sure, I'm going to err on the side of talking about it. These should be hypoattenuating like parathyroid glands to the thyroid on the non-contrast phase. If you see a fatty hilum, that certainly helps. They exhibit something called progressive enhancement that people talk about in the literature, which is just to say if you look at the attenuation on the arterial phase and then compare that to the venous phase, these are two different lymph nodes in two different patients, the attenuation on the venous phase goes up. And then here's just an arrow highlighting that fatty hilum. Practically speaking, when I'm reading these studies, I will just go find some lymph nodes, either in the kind of level 2 station, perhaps, or in the mediastinum, and then I'll play a game. Basically, it's same or different, right? Does the thing that I'm looking at as potentially a parathyroid adenoma look the same as my internal control lymph nodes? In which case, I'll say it's probably a lymph node. If it looks at all different in any way, I'm going to err on the side of saying I think that could be a parathyroid adenoma and describe it. And so these are 4 different proven parathyroid adenomas that I would argue look different from these lymph nodes in attenuation on the arterial phase scan. All right, comes to our approach. So we've got our non-contrast arterial phase and our venous phase. And when I was getting started with this, the way I was taught, and I think the way most people do this, is they start with the arterial phase. And I've actually switched my approach to starting with the non-contrast phase, and I'll illustrate why for you in a minute. I use that non-contrast phase to answer the simple question, do I think this is thyroid tissue or not thyroid tissue based on the presence or absence of iodine? Once I've done that, I'll move to the post-contrast phases, especially the arterial, and ask myself the question, is this a lymph node, yes or no? And for the stuff that ends up in the pile of not thyroid, not lymph node, I'm going to be thinking first and foremost about parathyroid adenoma. And when I start with that non-contrast phase, it's not that I'm necessarily reviewing the whole scan. I'm really focused in on the periphery of the thyroid gland. And so I'll go just along the margins on both the axial and the coronal images and make a mental checklist of anything hypoattenuating up against the gland to then scrutinize on those post-contrast images. And the reason I do this is because I felt like I was wasting a lot of time starting with an arterial phase image and overlooking a lesion. So there is a 1.5 centimeter parathyroid adenoma on this image, and it's really hard to see. But if I go to the non-contrast phase, I see, okay, right between the right internal jugular vein and the right probably common carotid artery, there's this hypoattenuating nodule that's not thyroid. And then when I come back to the post-contrast, that doesn't enhance like a lymph node, and so that ends up being a parathyroid adenoma. We said earlier that some of the times the patients have low iodine in their thyroid gland, and this is one of the reasons we really like the dual energy approach. So we're acquiring our non-contrast phase using dual energy so that we can take advantage of some of the properties of that iodine in the thyroid. So at 70 keV, which is kind of comparable to a conventional single energy image, you can see that the attenuation of the parathyroid adenoma graphed in blue is different from the attenuation of the thyroid gland graphed in red. But look at what happens when we go down to 40 keV. We really accentuate that difference, and this is particularly helpful in patients with lower thyroid iodine content. And so rather than doing a virtual non-contrast image, which would take out the iodine both from the contrast enhanced phase from the injected iodine and the iodine in the thyroid, we acquire a dual energy non-contrast image. Here I'm showing you parathyroid adenoma labeled in P, thyroid labeled with T at that sort of typical 70 keV virtual monoenergetic image, and contrasting that with the 40 keV. And this is not simply a trick of windowing and leveling. The window level settings here are identical, but this increases my confidence that something is non-thyroidal or is thyroid based on how it looks on these low KeV virtual monoenergetic images, which is taking advantage of the K edge of iodine around, I think, 36, 37. And so in practice, what this looks like, we've got arterial phase images on the screen far left, and then our 70 keV non-contrast images in the middle. And one of these is a parathyroid adenoma, one is an exophytic thyroid nodule. And you might wonder, is there a little hyperattenuation in that lower middle image? Maybe that's the thyroid nodule, maybe the thing above is the parathyroid adenoma. But when we go to the 40 keV non-contrast, I think that attenuation in the exophytic thyroid nodule is much more conspicuous, and the hypoattenuation in the right inferior parathyroid adenoma is more convincing. And so that top row ends up being the adenoma, that bottom row ends up being the thyroid nodule. And I've got numerous other examples of where these 40 keV images have helped me. What about where do we look? When I'm looking for superior glands, I start right about here. They're often sitting right there. If I don't see them, I'll broaden my search. And it's a pretty big area up and down because, like we said earlier, they can be low in the neck. Here are just examples of superior adenomas starting from superior, moving inferiorly. Note they do not all look hypervascular, but many of them do. This is that same search pattern in words. I won't read it to you, but it's starting from where they're most commonly located and moving to where they're less frequently located. And a key thing here is you can't stop as soon as you find one because they could have supernumerary parathyroid glands. And so you kind of have to complete the search pattern regardless of whether you find something early or not. Inferior glands, if I'm struggling to find them, I'll pull up the coronal image and look right along the inferior border of the thyroid. And if I don't see them then, I'll extend my search down into the mediastinum. This is an example of an adenoma hugging the bottom of that left thyroid lobe. And you can imagine on an axial image, you're going to volume average right through that fat interface. I think on the coronal, you get a chance, especially with the non-contrast image showing that it's hypoattenuating relative to the normal thyroid gland. Just some examples of inferior adenomas starting higher in the neck and moving lower into the mediastinum. And right here is commonly where I'll see them on that coronal image. Search pattern again in words. In the interest of time, I'm going to move through this. We got several more slides, but I'll try to wrap up in the next 5 minutes or so. Another pearl I'll share with you is to review old imaging. And so this was an older patient, again, with the same disease we've been talking about this whole time. And this was one looks like we injected the left side. I'd rather inject the right. Looks like we didn't really get the clavicles as low as I would like. And so I'm wondering about, is there maybe a little lesion right there, or is that just the thyroid gland? It's hard to tell. They had a cervical spine CT from 7 years earlier, which is grainy. It's a lower radiation technique, which is appropriate. But this 7-year-old CT was what made me more confident. Yet, yes, there is a hypoattenuating nodule on the posterior aspect of that left thyroid lobe. We'll describe it as a candidate. They went to surgery, and that was proven to be a single parathyroid adenoma. All right, so that brings us to what the surgeon wants to know. To plan the operation, what they really want from us is how many candidate lesions are there? How big are they? Where are they located? And again, we're going to want to be specific. And I think refreshingly, they want to know what we think. If we, this is likely a parathyroid adenoma versus, I think this is probably a lymph node, but I'm going to describe it for you just in case. And what that allows is then they can sort of have contingency plans. So they take out the first candidate, and that PTH is either going to drop or it's not going to drop. And if it doesn't drop, instead of this like, oh no, what do I do moment, it's okay, we'll go to candidate 2, candidate 3, candidate 4. So for me, I feel like I have done my job if the patient is cured before they have exhausted my list of candidate lesions. And if they've gotten to the point where there are no more candidates and their PTH is still high, then I feel like I haven't done my job. We said earlier, if you've got one candidate that favors single gland disease and the minimally invasive approach, whereas multiple candidates favors multi-gland disease and the bilateral neck exploration. Hopefully you remember what happens if we see no candidate lesions. They still have the disease, they still need surgery, but they're going to require the bilateral neck exploration, probably due to multi-gland disease. We said the bigger the lesion is, specifically if it's greater than 13 millimeters, the largest candidate, that favors single gland disease, according to the literature. Whereas if it's small, largest candidate, less than 7 millimeters, favors multi-gland disease. But that's, in population in large numbers, on any individual basis, we have to be careful and not fall victim to satisfaction of search. So 46-year-old female, we see this 13 millimeter candidate, right? So that size would favor single gland disease. But we also have this smaller 8 millimeter candidate. Doesn't look like thyroid, doesn't look like lymph node. It's got some cystic stuff in it. It's a little funny. Both of these ended up being parathyroid adenomas at surgery. After both were removed, the patient was cured. Here's another illustrative example of a nearly 3 centimeter adenoma in the right neck. If there was ever a time I was tempted to stop early and just like go on to the next case, it was this one. This is so big. But I wasn't sure, what is that? Not thyroid, not a lymph node. Better describe that. And then here's another thing. So this would be, one left inferior candidate, and then here potentially another one on the same side, further behind the clavicle. These are just some sagittal images. One of those on the one plane I thought could be a vessel, but I wasn't convinced. So I ended up describing all 3. And all 3 had to be removed at surgery to cure this patient. And I got a call from the surgeon afterwards, so thankful that I had described that second left inferior candidate, because he said he never would have looked there otherwise, because he would have assumed that he'd already found the left inferior gland and there must be a gland somewhere else, maybe in the right inferior, the left superior position that he was missing, that this patient had 2 left inferior parathyroid adenomas. These are what I've found my surgeons to feel are the preferred landmarks, and the big ones are the tracheoesophageal groove. That tells them how deep they're going to need to go, and it tells them what the risk is going to be to the recurrent laryngeal nerve. And then the cricoid cartilage is a consistently palpable landmark, and they consistently expose this with their incisions. And so that tells them kind of how high or low in the neck if you describe the adenoma relative to, I use the inferior margin of the cricoid cartilage anteriorly because that's what they'll feel. We talked about some of the mimics. We talked about how to tell them apart. We talked about the importance of the aberrant right subclavian artery, right? We want to keep our surgeons and by extension, the patients and ourselves out of trouble. And we talked about if we see something ugly in the thyroid gland, let's get that worked up too, because they might be able to have their parathyroid surgery and their thyroid cancer surgery all at the same time. I'm not going to read this, but this summarizes each of those things they want to know and why. And if you kind of have an understanding of this, then you can move to a report template or structured report that includes all of these elements. And that's what we've done in our practice at Wake Forest. So in summary, this is a disease that I think is associated with pretty high morbidity and cost. I think it's more common than people realize, and it's a worse thing to live with than people realize. It's diagnosed with blood tests, basically. We're going to cure it with surgery. Our role as radiologists is really preoperative localization to try to facilitate the optimal operative plan. I think if you know a little bit about the embryology and the anatomy, it gives you the best chance of being successful. And so I really hope we can work together to try to leverage the strengths of all of these imaging modalities to maximize patient access to curative minimally invasive surgery if appropriate. In my practice, I like to start with the non-contrast phase. I'm going to use all the information available to me, whether that's old films or other modalities. Don't fall victim to assuming low in the neck is an inferior gland. Don't get too fixated on enhancement pattern, and don't fall victim to satisfaction of search. And with that, I will say thank you for your attention. Thank you for being here, and I welcome any questions.
Paul, thank you so much for such an outstanding, very illustrative and educative session. This will definitely directly impact the patient care and radiology education across the globe. Thank you so much. So let's move on to the Q&A session. I have a couple of questions. Question one is, can I ask about 4D MR for parathyroid? Is the phase that being used the same as the 4D CT, like arterial phase 30 seconds and venous phase 60 seconds? And is there any additional sequence that could be beneficial, like perfusion or any other?
Yeah, so I can speak a little to our MRI experience. I think there are some papers in AJNR. I think Ali Sepidari is maybe the senior author on them, and maybe Dr. Jennifer Becker is one of the first authors that outlines at least their approach. And I believe there's also a paper maybe in European Radiology, or maybe it's EJR. So there are some institutions where parathyroid MR is kind of like approaching a first line test. Like they might do that before they would do a parathyroid CT. At our institution, it's really more of a they can't get a parathyroid CT, then we'll offer parathyroid MR. So that's anaphylactic contrast reaction to iodine. Some of our renal patients, despite what the kind of college, radiology college, despite what the kidney college say in sort of their joint paper, I think in radiology, sometimes they don't want to give those patients iodinated contrast and we'll do MRI. I think the most useful things to have for the MR protocol, one is diffusion, actually, because the lymph nodes will tend to light up on the diffusion, whereas the adenomas often don't. Diffusion in the neck is hard. So like I will admit ours don't often come out as nicely as I'd like, but I think it's worth trying that and hopefully optimizing it. T2, most adenomas are going to be bright on T2, whereas the thyroid gland, it tends to be darker. I think one of the challenging things with MR is, unlike CT, where we have this non-contrast phase that's super helpful for thyroid versus not thyroid, for MR, we don't yet, to my knowledge, at least have that sequence. And so I think the T2 is maybe the closest thing. To the post-contrast question. So because unlike in CT, where each phase is more radiation to the patient, I've got no interest in doing more than 3. And I think there's a reasonable argument to be made to just do 2, do the non-contrast on that 30-second arterial. In MR, there's no penalty. And so we've built ours so that it is almost like it's a time-resolved MRA. It's not exactly that. It's a kind of a 3D fat-suppressed T1, but we try to run it very quickly, and we might run it like 10, 15, 20. We just set it to run for, I don't know if it's 7, 8 minutes, something like that. With the hope that, okay, if they swallow or move on one of these, we'll have so many others to try to sort it out. It tends to be those earlier phases are the most useful. but that's kind of how we've built it. And I don't have all of those details in front of me, but I'd be happy to try to share what we have. I'd say from the image interpretation, I feel like there's a saying, sometimes it's better to be lucky than good. And I feel like our MRI reads have been right, but it feels almost my confidence in the interpretation is nowhere near my confidence with CT. And so some of that may just be my own limitations or inexperience with it compared to CT. But I think with CT, when the images are good, like they're really good and the confidence is high. And with MR, at least in my hands, it doesn't quite get there, though with more practice, maybe someday it will. So hopefully that's a long answer to a simple question, but hopefully gives you at least one person's take on MRI. And I can try to put some of those papers in the chat. But anyway, there's some nice ones out there, and their results are quite impressive in their hands.
Thank you. Next question. Is it beneficial to use iodine map in spectral CT to identify the parathyroid lesions? I think you
Yeah,
said that in there.
I think it's a thing to I think I've seen some research studies looking at that. I've seen people that like to do color maps. I think whatever helps you see what you're looking for is worth trying. I It's not something we're doing in our practice. I feel like I'm okay with the grayscale, and my colleagues I think feel similarly. But I don't think there's any reason not to try it, and you never know what's going to help you. And if you find something that works, you know, share it with the world through this forum or through writing a paper or whatever it is. So yeah.
Thank you. Next question. How do you differentiate the normal parathyroid gland and adenoma if it's small in size?
Yeah, so it's tough. We have published some on that. We've looked at that. So I'll put these are two MRI papers. I was so Dr. Kambiz Nael is kind of the senior and lead, and then Jennifer Becker is the lead on one of these. So there's no perfect way. Adenomas can be small, and presumably normal glands can be kind of big. Just like in cancer, head and neck cancer, right? We have these size thresholds of, you know, lymph nodes, short axis, long axis, et cetera, depending on where it is, that are imperfect, but useful to try to separate as best we can. And the threshold for us is seven millimeters. If it, and this, I can try to find this paper and put it in the chat too, but if the finding, the parathyroid finding, is 7 millimeters or larger, based on a small study, further work needed, those tended to need to be removed for the patient to be cured of their disease. I say the bigger it is, the more likely it's going to be an adenoma. There are plenty of normal glands, probably at 7, 8, 9 millimeters. That just happened to be the cut point when we studied it. But if I've got something that's 3, 4, 5 millimeters, the way I'll describe it, the way I'll dictate it practically is, you know, so for me, it's, you know, there's a candidate, it's located here, it measures this. I think it's most likely to be, is it parathyroid adenoma, lymph node, et cetera. For these small structures, I'll say normal versus mildly enlarged parathyroid gland. And so for the surgeon, they know it's there. They know they can go look at it if the course of the operation is such that the PTH doesn't drop. And so again, I don't feel, if I call it normal or mildly enlarged or an adenoma, as long as they know about it and that patient gets cured, whether they had to take it out or not, then I feel like that was a success.
Thank you. I guess potentially the last question. What is your approach when contrast opacification is suboptimal due to patient physiology? Do you even trigger scan by thyroid HU?
Yeah, so we just do basically the timing, and so that works for many people. It doesn't work for everybody. There are protocols out there. I think at Kaiser they do, at Kaiser Permanente in California does a bolus track trigger, and that's totally like a reasonable thing to do. And that I think there'd be benefits potentially if you have more standardized, you know, arterial phase enhancement. We haven't felt like we've had to do that in the context of our practice. And just from a like trying to be friendly to our technologists, at least in our practice, they're often it's a high turnover job. People are always kind of getting trained up and learning. And I've found the simplest I can make it, the more likely it will get done that way. So we're not using bolus tracking to trigger. Places that do, I think they've used one of the arteries, either off the arch or the neck. I haven't come across using the thyroid as a trigger, but that's an interesting idea and not necessarily like maybe that's worth trying and looking at as well. I personally have not seen or heard of that, but there's plenty of stuff I haven't seen or heard of.
Thank you. Okay, in the interest of time, just we'll take one last question if you're okay. Uh, do you have any suggestions or comment about atypical parathyroid adenoma? How often do you see that?
Yeah, so we've had probably about as often or about as rarely as the parathyroid carcinoma. Um, so that's mentioned in that WHO 2022 update. I'm thinking of one patient fairly recently that maybe 4 or 5 years ago there was a small nodule not commented upon, and then it was this like 3 or 4 centimeter mass. That's another one like the carcinoma that I think is typically a surprise when they take it out. Like adenomas can be big. Sure, the bigger it is, maybe the more likely it's going to be one of these atypical tumors or a carcinoma. But I think that's hard to say prospectively. And then what has been the challenge in those people is then what do you do? If it's cancer, you know you're going to have to be monitoring them. If it's this atypical tumor, do you surveil them as well for occurrence? How carefully do you monitor them? Do you just do periodic blood testing? So those are some of the issues that at least our head and neck tumor board have wrestled with in the small number of patients that we've had with that tumor. But I'd have to look to see, is it more common than parathyroid carcinoma? Are they similarly rare? I don't know the answer to that. In my experience, I have not seen a lot of either, but a handful or less. This link I just put in was our attempt to decide, to guide biochemically successful surgery using a size threshold that we have validated but haven't published the validation yet. So that's on my to-do list.
Yeah. Thank you, sir. Thank you, Dr. Bunch. Really appreciate your excellent, very educative session. Um, and I'll also like to thank all the attendees for joining this, irrespective of the time zone. And again, apologize for the initial 1 hour confusion which happened this time. But going forward, our next sessions would be at 9 a.m. Eastern time. I just wanted to bring that in attention. Thank you so much, Dr. Bunch. Really appreciate your thoughtfulness and your education support.